Hello, everyone, and welcome to today's webinar, the first of our Vulnerable Populations series on our 2024 calendar, Building Partnerships, State Brain Injury Programs, and Overdose Fatality Reviews, offered by the National Association of State Head Injury Administrators. We are so delighted that you're joining us. I'm Maria Crowley with NASHIA, and I'm going to be your moderator for today. Closed captioning is available, as you may already know. You can enable that at the bottom of your viewing window. If you need any assistance during today's webinar, just send me a chat or go directly to Zoom's support site. And if you have any questions for our presenters, you can add those to the chat or the Q&A, and we will do our best to address those as we go or at the end. A little bit about our organization. NASHIA is a national nonprofit created to assist state government in promoting partnerships and building systems to meet the needs of individuals with brain injury and their families. We would love to have you join us. We're also a membership association. We have several categories that might work best for you, and there's a lot of benefits that come along with those, so consider joining us. We do a lot of provision of technical assistance in addition to the numerous training opportunities that we offer, and some consulting supports as well on a wide range of topics. We do offer general certificates of attendance and social work CEs for today's event. Certificates of attendance are free if you're a NASHIA member, and social work CEs are at a reduced rate if you're a NASHIA member. If that is the case, you have the opportunity to get a promo code. If you'll email me, I'll share that out with you. And you'll receive an email tomorrow that has a link with a general feedback form. Once you complete that evaluation, you'll be eligible to get your certificates of attendance. If you have any questions about that, you can contact me. And as always, all of our recordings are archived, and you'll find all the information on our website. So with further ado, I want to introduce you to today's presenters. You all have had an opportunity to see some information from our marketing announcements about them. So I'm not going to take time to read through those with you, but we have a very important topic we're going to be addressing, and these women are going to be walking you through that topic as we go. We have Anastasia Edmonston, who works for Maryland's Behavioral Health Administration and is the grant coordinator there for traumatic brain injury. We have Melissa Heinen, who's with the Overdose Fatality Review, harm reduction manager with the Institute for Intergovernmental Research, which is IIR. And last but certainly not least, we have Zeta Ricker, who is NASHIA's Director for Strategic Partnerships and Policy. Welcome to the three of you.
Hi, thank you so much, Maria, and always happy to be joining with NASHIA to share some important information with folks. And you can go right to the next slide. So I'm just going to give you a few fast facts and kind of set our framework for brain injury and how it might intersect with opioid use disorder and also overdose fatality review. So this is a well-known relationship between traumatic brain injury and substance use disorders. So those with a problematic use of alcohol, for example, pre-injury, will resume their prior level of use following a 2 to 3 year honeymoon period. And this honeymoon is actually referred to in the literature as such, and I have observed it with individuals that I have worked with in outpatient brain injury community programs, those whose substance use was problematic to the point it was a factor in the circumstances of their injury, so such as initiating fights, driving vehicles, cars, jet skis, motorcycles, and mopeds, while under the influence that resulted in serious brain injury. And after a period of enforced sobriety, because of hospitalization, because of rehabilitation, as well as the necessary supervision that family and friends provided as they were healing their brains and bodies. And folks very sincerely expressed remorse about the situation they found themselves and their families and loved ones in due to some misjudgment on their part. And they sincerely believe that they are going to abstain. So I always will believe people when they say that. I think that is absolutely true. However, we know that upon discharge, they lose a lot of that structure. And so they may be lonely. They may have difficulty finding employment. And so going back to familiar people, places, and things, the folks that they were hanging with prior to that injury may reinforce the comfort with resuming use. And also, again, isolation if they can't exactly go back and pick up their old life. And so it's highly likely that people may begin using substances at the level they were using before. And we do know that childhood traumatic brain injury may predispose folks to adult high-risk substance use. So following people over time, they are more likely to engage in problematic substance use than those who did not have a history of brain injury, even if it was mild. And the longitudinal study done in Christchurch, New Zealand, found if that mild injury, and when I say mild, I mean no loss of consciousness or very brief loss of consciousness, were 3 times more likely to have a diagnosis of alcohol or drug dependency by late adolescence or early adulthood. If they had that injury before the age of 6. So noting these correlations, not causation, but it just should give all of us, who work with people, that this is something we need to be aware of. And I'm really grateful that there is additional research that's focusing on the correlation, the connection between adverse childhood experiences and brain injury. Next slide, please. So I just wanted to, I always talk about this when I talk about this topic. So you've heard me before, you probably heard the term a perfect storm. And I'm quoting Dr. Adams and Dr. John Corrigan, who've dubbed the relationship between opioids and brain injury as the perfect storm, because individuals with traumatic brain injury are often prescribed an opioid to treat post-injury pain. And the pain is real. People have terrific headaches, sometimes for years post-injury. They'll have orthopedic injuries. There's something called heterotropic ossification. No test on that term, but it just means that there is bone growing in joints, and that's very, very painful. And so it's understandable that people need to have their pain treated, and that does set them up for problematic use or misuse. So accidental poisoning among this population is 11 times higher following a moderate to severe TBI. So that is over 24 hours of unconsciousness, compared with characteristics of people who die of other causes. And that is most likely because, when did I take that last dose? Oh my goodness, I can't remember. I'm sure it's fine if I take more than prescribed because I'm really in pain. And then, of course, resuming pre-level use of, say, alcohol is going to make that person so much more at risk for overdose. We do know that methamphetamine has been found, at least in the Maryland overdose fatality reviews. Fentanyl is being added to the supply. And so even before the addition of fentanyl to methamphetamine as well as cocaine, methamphetamine is just on its own not good for a brain. And so you add that to somebody who may have a history of brain injury or be vulnerable to brain injury, and really may put them at a disadvantage in their ability to navigate the world. Next slide, please. And I just want to provide you with a level set terminology. So acquired brain injury is our umbrella term. And under that, we have TBI, or traumatic brain injury. That's from an external force or blow to the head. An assault, sports related, improvised explosive device in regards to our service members, a fall, especially for our older adults, and then a non-traumatic TBI that can happen after a stroke, an infection like meningitis, encephalitis, strangulation. We see that intimate partner violence and other events that can lead to a loss of oxygen to the brain. And that leads us not only to cardiac events as a possible culprit, near drownings, but people who have survived an overdose or overdoses may have little hits to their oxygen supply to their brain. And that can cause similar challenges with memory, thinking, attention, behavioral regulation that we can see in folks who are living with a TBI. And now I'm going to turn it over to my colleague, Melissa.
All right, thank you. Thank you for that level setting. I always learn from Stasia something new. So it's fun to be up here presenting with her and the other colleagues. So I'm here to talk about overdose fatality review. I will refer to it as OFR throughout today's presentation at times. And I'm with the Institute for Intergovernmental Research. And just so everyone knows, IIR, which is what we call our organization. We are one of several training and technical assistance, or TTA, providers under the Comprehensive Opioid Stimulant and Substance Use Prevention Program, COSUP program, which is a Bureau of Justice Assistance federal agency program. And our lane is to help any and every jurisdiction and agency and person who wants to learn about OFR, regardless of funding. So we get funded support through CDC and BJA to support communities. So that is why I'm here to speak. I've been with IR almost 5 years and have a background in epidemiology and injury prevention, overdose, suicide, etc. So with that, we'll go to the next slide. So when we talk about an overdose fatality review, this is where you bring multidisciplinary partners from across the community together with the goal of reducing overdoses. And everyone who's participating in that goal to reduce overdoses needs to and recognize that substance use is a disorder that's chronic and treatable and preventable. And with the goal of preventing overdoses, we want to best understand at a community level and at the individual level what may have contributed to the overdose death. And so we bring data from all over, from law enforcement, public health, healthcare, treatment, and we try to, through this shared data, identify missed opportunities for prevention and intervention so we can inform our response and how our systems are coordinated, all with the goal of continuous improvement, not only continuous improvement of individual agencies or partnerships, but also the data and our understanding and the overdose fatality review process. So if we go to the next slide, the way this works is typically the OFR is hosted by one agency. Often it's an agency who has it as part of their mission or vision to be in the overdose prevention space. They should be neutral conveners. So in many communities, this lands in a public health agency, although that's not the only agency, but that is the majority of them. And this convening of multidisciplinary team members begin by looking at the community data, understanding drug trends, what services are available, what are some assets in the community, as well as begin to understand which community members, cohorts, geographical locations, there is an increase in overdose deaths. And all of this is to provide some community context and to understand maybe the what is happening, but maybe you can't tell the why or how it's happening. And that is then why you would select cases to review. And so you bring the team together and you co-create an understanding of this individual's life experience to find out what connections they had in the community, what services, systems they touched, and how those systems coordinated and responded with the individual. So the idea is you create a timeline, you kind of see periods of increased stress or increased use. You might identify prior non-fatal attempts or non-fatal overdoses, but through this process, you begin to see where there was a missed opportunity for prevention or intervention. You may notice when the systems didn't coordinate and someone fell through the cracks. You may identify a time period where maybe an intervention wasn't provided in a health system that could have potentially connected them with medication for opioid use disorder or something like that. So through this process, through this continuous improvement process of understanding, what you're able to do is find these moments and make recommendations for improvement. And these recommendations may be agency specific, like you might want to have training for your staff. It could be interagency, so maybe it's developing a warm handoff process, or it could be a community level recommendation, such as applying for grants for more naloxone distribution. But regardless of the recommendation, there is a process and a plan to work on developing that recommendation and ultimately presenting it and sharing it in a way with a governing committee to have accountability. So when we talk about the OFR, people often think about, we're only talking about the second bar here, which is that deep individual case review, but we're really actually talking about this much larger framework where we're taking a community understanding of what's happening and looking at cases to figure out why it's happening and how it's happening, and then developing recommendations so we can make change. So we can go to the next slide. This is what I mentioned, right? You want to look at your aggregate data, your case level data, and have some effort to develop a recommendation out. And that governing committee is really that structure that you are held accountable to make sure things are moving forward and happening. Next slide. So when we talk about a lead agency, I mentioned it's often public health. It doesn't have to be. There are 3 distinct roles that need to be involved in this, but we want someone who's coordinating and making sure everyone knows where they need to show up, what information they need to share. The facilitator is what we call the secret sauce. This is the person that really builds those relationships, builds trust, and establishes a shared understanding across the members so that we can pull out more information and really begin to find the root causes or those missed opportunities. And then because we're EPIs and we're public health and we care about all that, we also need to keep track of what we're learning so that we can begin to have a shared collective understanding as we review more and more cases of where we're consistently seeing missed opportunities, and we can better describe what is really happening in our communities. Next slide. So when I talk about data that you might want to understand from a community context, we're talking about non-fatal overdoses. We're talking about where has naloxone been distributed and administered, which there's a software tool that's used by many EMS, emergency medical services, and law enforcement or public safety, which is ODMAP. We're talking about what harm reduction services are available. Have there been drug-related arrests? How about seizures? What are the drugs that we're finding in our toxicology, just as Stacia mentioned in regards to trends related to that. And then also really looking at social determinants of health. So not only access to treatment and services, thinking though about housing and the importance of that. We encourage people to really understand the social context in which the person lives. So do they have adverse childhood experiences when they were younger, and things like that, as well as just, is this part of a larger overdose trend, either a spike within a similar time frame or representing a certain increased risk cohort. We'll go to the next slide. So all your members that you come together on this multidisciplinary team, you know, when you think about, okay, we're going to want representatives from treatment, we're going to want representatives from healthcare, we're going to want representatives from law enforcement, all those touch points in the community, it can be hard, especially in a larger community, to determine who to invite. You might potentially have 9 treatment providers in your community. So you really want to look at those that are willing to partner, those that are champions for prevention, preventing overdoses, and provide quality services are known to play well in this sandbox with others. They can consistently participate. They are good stewards of data and keep confidentiality. And like I said, they're able to champion and really move forward. They really want to see change. You go to the next slide. This is not an exhaustive list, but as you think about, if you were to close your eyes and try to map out in an individual's experience throughout their life, where they might touch different systems or agencies, you want to bring those representatives so they can speak to both in general, how they provide services and support to an individual who may interact with them, and also provide detailed information about the individual in particular that the case is reviewing. Go to the next slide. So I mentioned the governing committee. So when you think about the overdose fatality review, it's all those touch points, sending a representative, sharing data about the individual, saying, oh, we did see them in our emergency room 3 times. Once was for a non-fatal overdose. We have that. Those are your front level, frontline staff, those that are doing the day-to-day work, those that can tell you this is what really happens, not just this is what our policy is, but this is actually what happens. Your governing committee should be a different level within an agency. These should really be your decision makers, those that are able to politically endorse, and I don't mean politically like elections and stuff like that. I mean, like using their esteemed power to kind of maneuver things, right? So they might be someone such as a commissioner or a medical director, or someone who can say, oh, this is important. Let me go see if we can go back and shift some funding, or let me see about going back and changing our policy, or yes, we should. Those that can provide leadership and support for implementing it. They're probably not the ones who are going to be doing the implementing of the recommendations, but they can put some of their support behind it and make things happen. This sometimes can be an already existing task force. In many communities, there is a big initiative to bring leadership together to try to address the overdose crisis. So this could be already convening group, or this might be a group that needs to be formed to really support at a higher level the recommendations that are identified through the overdose fatality review. So go to the next slide. That accountability is really important. And we find some things that make OFRs very successful are A, who's convening and facilitating those meetings, and B, how are they having a shared accountability, and how are they moving forward with implementation of those recommendations? And that can really come by having this body that is looking to you going, what are you finding? Because as you all are aware of, I'm sure, in most communities, the overdose crisis is not drastically improving. And so there needs to be some urgency in responding. And this can be a way where all those who have a role in prevention can come together and find direction to make the next step forward to really try to change the course and prevent these preventable deaths. So this is an example of in a local community who might be good to recruit for governing committee. We'll go to the next slide. So I know that this was really in the weeds. You're probably like, why do I need to know this? I just want you to see the depth and breadth of the type of representation we have on an overdose fatality review, and really encourage those of you who come from a space that maybe traditionally hasn't been tapped to reach out and consider participating in an OFR. And we're going to have more conversation about that here in a bit. But the whole point of an OFR is to improve the community conditions and prevent future overdoses. And so when we think about that as like the point, one thing that I want everyone to know is overdose fatality reviews are growing across the country. And we're seeing them in over 300 communities across the country and even more. I bet we'll be, I don't want to estimate, but I wouldn't be surprised if we're closer to 400 in a year. So it's pretty likely, and we know of them in at least 40 states, and we're probably going to be close to 50 in the next year. So when you think about this, it's very likely that there is an overdose fatality review happening in your state, and very possibly in your community. And the whole point of this group coming together and doing this hard work is to identify and make improvements. So you will want to know if there is one in your community. You may want to participate or be aware of what recommendations they're finding. You might not want to participate within an individual case review. Some states have limits on who can participate and stuff like that. But you probably would want to maybe be a part of a recommendation subcommittee. So I really encourage you to follow up after this and try to see who is doing this work in your shared space, because they're very likely coming up with findings and recommendations that, even if you're not a part of the OFR, could be useful to you in your role of trying to better service and be available to individuals who use drugs, to make sure that they are getting the resources they need and ultimately, preventing their overdose and hopefully thriving, and can be provided services to begin recovery. So with that, we'll go to the next slide. So throughout this whole process, by bringing this group together, ultimately what ends up happening is not only are we able to address the overdose crisis, but we're able to address other public health or complex public safety issues. It's not unusual, especially in rural communities, where we will hear of the OFR connections and collaborations, allowing the community to address something such as when COVID happened. When COVID hit communities, people had a role and they had an established OFR. They were able to pivot and use their Rolodex to reach out because they had this shared understanding of who else in the community is available to support the community and what are they doing. So we've also seen communities that have been able to pivot and address the suicide contagion. So through this process of coming together and trying to address what is needed to prevent overdoses, we're also finding that they're able to have a shared understanding about how each other's agencies work, the community context. They're able to optimize that capacity, know who to call upon or to partner with, and they're able to hold each other accountable. This effort is not going to be effective if it's led by just one agency and they're doing all the work. This is a multi-agency, multidisciplinary response is needed. Okay, if we go to the next slide. So we do have a video. I don't know if it will play. If we're able to click on it, hopefully it will play. If not, we can skip it in the interest of time, but I'm almost done. And I think this does a nice job explaining what an OFR is. Are we able to?
Let me see if that looks like it's connecting.
If it doesn't, that's fine. I know oh, here we go. Okay, hopefully this works. I'm unable.
OFR is a overdose fatality review, which sounds.
Oh, when you went on mute, it ended our ability to hear. Can you unmute? Sorry, everyone.
I can hear it. You can't hear it.
Not when you mute yourself, I can't. So
Hey, good to know. Let me start that again.
thank you, everyone.
An OFR is a overdose fatality review, which sounds like it's just a meeting, but there's way more to an overdose fatality review. It's a team of multidisciplinary partners that come together to review fatal overdoses. So those are frontline practitioners that come together to share what they know about an individual that has overdosed, to really put together this really deep picture of what's going on with overdose fatalities, with the intention of developing recommendations for prevention and intervention that are actionable.
I think when people think about an OFR, they think that it's simply reviewing the case of someone who's lost their life to an overdose, but it's much more than that. It's the partnerships and the representation around the table. It's the work that comes out of OFRs with recommendations. But I think that it's this incredible safe space that partners can come together and be real with one another and talk about how as a community we can do better work.
The goal of an overdose fatality review team is to really look at the gaps in services and how we as a community can help people who have substance use disorder really figure out what things they need and what issues that our communities are seeing that we may not know. But through that overdose fatality review meeting, we discover, oh, hey, our jail could use a treatment center within the jail, things like that. You know, I deal with people in the treatment community all the time, but having those connections to the Department of Child Services, the coroner's office, and the other agencies that are involved, you know, we're just a phone call away. And if I have a question, I can call them because we have that personal relationship because of that overdose fatality review. So those relationships are really powerful and really help every agency that's involved in the program.
You have everything from public health representatives to emergency department and hospital representatives, law enforcement, medical examiners, coroners. So there's a very broad range of stakeholders involved with this. I think the other piece of what's important with the collaboration in an OFR is that when these stakeholders get together, they form relationships that then go outside of the OFR meeting. And I've seen this time and time again, where conversations continue, new partnerships are formed, new collaborations happen outside of this, new efforts and new programs start to happen outside of this as well. I don't think there's any other way that we can gather together different aspects of our system of care and even adequately look to see if this truly is a system for the person who is passing through. But I think with an OFR, what we typically see is that the person who's moving through touching these different systems, this is not seamless. There are gaps. There are places where we can do things better. I don't know of any other way where we can truly see those gaps and barriers than with an OFR.
This is the most important work that I've ever done. Our OFR team has become a platform for community change. And I say that because the relationships that have been built, we've been able to make change happen beyond what's related to substance use and overdose. You know, looking at Handle with Care and connecting police with schools. It is related to substance use and overdoses, but it's looking much more preventative. And so OFR has been able to be that platform, which makes this work so amazing and also really hard.
There is something magical about overdose fatality reviews. When you get the right people in the room, you get them to this place of sharing and trusting that I've never seen. And once they start implementing those strategies, they keep coming back because they know that this is the place that we can accomplish the reduction in overdose deaths.
Thank you. Thank you for that. I know that I said a lot of that, but I think the video kind of shows from a community's level why this might be useful. So I know my time is coming up, so I'm just gonna have us go through some slides pretty quickly. So how do you do this? We have resources and tools. If we go to the next slide, one of the tools that we have a whole OFR tools website, but we have a data system, and we were able to work with Stacia and others to make sure that this data system really captures the important information. And if we go to the next slide, you can see we cover a whole range of information within the case specific summary, including trauma history, health history, substance use, social services, a variety of elements, life stressors. And if we go to the next slide, you can see here we try to capture information about possibly injuries and possibly brain injuries, and whether that brain injury was a contributor towards the death, or if they had a history of it and it didn't contribute to the death. We also ask if they were receiving medical care or treatment for this injury. In this case, I checked the brain injury. If we go to the next slide, you can see, and I've just learned the acquired is the overarching, but we asked in regards to, when did they have the acquired brain injuries. So if we go to the next slide, we also have a next of kin interview. We provide trainings for free on how to do next of kin interviews. And here is where you really can begin to better understand what the system client reports don't share, which is just the individual as a human and their social constructs and some of their history, such as whether they were not showing up for school, if they had a car crash in another state. And you can begin to see potentially with the lens of acquired brain injury, how brain injury may have played a role in some of their interactions with services or their risks for the overdose. And if we go to the next slide, you can, if you're at all interested in OFR, want to learn more, you can request TTA. It's free. It's available to anyone, again, regardless of funding. And we'll go to the next slide, which is, this is the best way to get a hold of me or our website. If you go to ofrtools.org, you should find a host of information to begin your journey or begin your partnership with your local OFR. And I think with that, I get to pass it back, and I appreciate everyone's attention.
Thank you so much, Melissa. That was great. And I learned something new, as I always do every time you speak. Melissa and her colleagues also join our state overdose fatality review technical assistance call. So very fortunate that I get to see Melissa more often than the random webinar now and then. So I'm going to talk now specifically about our experience here in Maryland. Our state federal traumatic brain injury grant is located within our Behavioral Health Administration, which is located within the Maryland Department of Health. So I'm very fortunate that the work that we wanted to do and can do is really supported in part by where we sit amid the public behavioral health and public health system. So these are my suggestions. These are things that I've done. You would think would be easy peasy. Well, there's the brain injury people. Let me come talk to them about, overdose fatality review. It doesn't happen that way. Or huge administration. And so you have to reach out and build those relationships. So with the local health departments, we've been training them for years on traumatic brain injury and mental health and substance use. So that was a great setup to then segue into the OFR setting. Learn the vernacular and terminology, become familiar with who is on the team and how their expertise fits into the recommendations that are made. For me, I know all the terminology about brain injury, but I don't know all the terminology around drug tox screens, et cetera. So when I would get the information before the next review, I would spend quite a bit of time looking up different medications that were found in people's tox screen to educate myself, but also to know, were they taking a medication that's often given for people who may have had a history of traumatic brain injury, such as a seizure medication. So unless somebody has been identified in the medical record as having a traumatic brain injury or an acquired brain injury from an overdose, say, in their medical record, it's not going to be indicated on such, at least in our keyboard, or not our keyboard, our database for the OFR coordinators, because they have to go on the hard evidence. But that doesn't mean that there might not have been an unrecognized brain injury. And so I try to listen real carefully and to talk about other risk factors and clues about brain injury. Educate yourself if you have an opportunity to engage with your OFRs on best practices, harm reduction strategies, and trends in your communities and what they might mean for people living with brain injury who use drugs. And if you can, if it's an option for you, see about joining an overdose fatality review team. I'm trying to remember how it all started for me about 5 or 6 years ago, but I had a relationship with somebody who worked at the state level, and she thought brain injury should be involved, invited me to talk to the entire state meeting of OFR coordinators, and then we got a federal grant. And so it all kind of came together, and I sit on 2 teams right now. And what I do is really listen. I do a lot of listening because this is not my wheelhouse. It's becoming more comfortable for me to speak up. But I'm learning so much from law enforcement, from the OFR coordinators and folks who work in the schools. When I walked in and I saw somebody from the public schools, I thought, of course, we need that feedback. What happened during their academic career? So you can go to the next slide, Maria. Thanks. So I do have to just give a huge shout out to a big part of our OFR process, as well as a huge part of our public behavioral health workforce. We have a very robust workforce of certified peer specialists here in Maryland. And so when we talk about OFR, as Melissa, I think, already stated, we want to know what we can do to fill in the gaps. So we have less people to review. Basically, we want to save lives by knowing what are some of the missing components that might support people who use drugs and get them into treatment if that is their choice, at least to keep folks from passing from an overdose. So, peers are folks who have lived experience, often of substance use disorder and or mental health conditions. And the peers here in Maryland are everywhere where people who are perhaps vulnerable to overdose are. So they're in prisons and jails, they're in our hospitals, emergency departments. One of our local jurisdictions has peers who go to the bedside of individuals if they've been hospitalized after an overdose. They go with the first responders. There are some teams that when there is a non-fatal overdose, they go right there. So they're right with the sheriffs, and they're there to provide initial outreach to the individual. And they're part of the OFR teams. They're part of our assertive community treatment programs, which are mobile psychiatric and mental health services, and on our psychiatric rehabilitation programs. They sit in our problem gambling treatment services. And this is something fairly new. Maryland now has a recovery-friendly workplace initiative. And that's something out of the Department of Labor and with our health department. And so I've already done some training with the peers who are working in certain sites that have been identified as recovery-friendly workplaces. So for people who are in recovery to be supported as they enter or re-enter the workplace. So that's really exciting. Next slide, please. So I know I might be talking a lot about our peer specialists, but I think they are the key, the secret sauce to really engaging with folks who are vulnerable to brain injuries or living with brain injuries. We've been training certified peer specialists as part of our workforce for, I would say, 10 years. And that has just they have become more and more a fixture employed in our mental health programs and through the state. So they're really folks that you want on your team if you have the capacity. And I'll also say, because these are people who have lived experience of substance use and mental health challenges, just by what we know from the research, they themselves may be living with a history of brain injury. And I'm always very cognizant of that when I'm talking to any group of professionals. And I cannot tell you how many times people will either say in the middle of one of our trainings, oh my goodness, that might explain something wow, I've had a brain injury. or my family member, they had a brain injury. And this is really helpful for me to help support them. And oh, I'm working with an individual who is diagnosed with a bipolar disorder, but he told me he was shot in the front of his head, and I can see the scar, and I'm wondering. And so, this is a workforce that really knows the people they are supporting in services. And so they can use their either personal and or the knowledge we're giving them to be brain injury informed in their approach to supporting individuals in our systems and programs. So we've been doing just a ton of training, and I won't bore you with reading those off, but we want to expose everybody in our public behavioral health system who works in the system to how brain injury intersects with all these systems: criminal justice, homelessness, employment. And so we've been doing these trainings, engaging with NASHIA actually, to have subject matter experts come in, give an hour presentation, and then we will follow it up, myself and Martin Kerrigan, who is a part-time grant employee, and we will discuss and have some folks talk about their own experiences. And it's a really wonderful way to have people process and digest the information, and hopefully moving forward, having it front of mind when they're engaging with people in the community and in programs. Next slide, please. Some of the other things, so again, these are just things we've done to kind of train up a certified peer specialist in brain injury. So if this is available in your state, if you have a good relationship, right, of course it's a good relationship, but I hope you have a relationship with your Brain Injury Alliance or your Brain Injury Association. That's our advocates for brain injuries, people with lived experience of brain injury and their families. And so our Brain Injury Association and the Maryland Training Center, which helps the certified peer specialists maintain their certification. We were able to provide a brain injury fundamental certificate. So it really gave a strong rooting in brain injury from a medical social point of view. And we were able to provide that free of charge to 23 certified peer specialists. And we also, again, in collaboration with our partners, we were able to offer an 8-hour person-centered thinking course offered by a certified trainer. So we had 13 folks go through that multi-hour training, and they hung in there and they learned so much. And I'd like to think that that again is enriching their ability to support all the folks in the community they're working with, but especially those who may have a known or unknown history of brain injury. Next slide, please. So I'm just going to give you a quick kind of overview. And these are slides that I've used when talking to, people who work in OFR. Sometimes you don't get a lot of information. So we're looking for those clues. So you can go on to the next slide, Maria. So these are just some slides that give you a story, because that's what OFR looks like. And OFR, to me, I've always been just really wowed by the respect and the dignity and the compassion when talking about people who are no longer with us because of a fatal overdose. And so you will hear the nuts and bolts and what was found, and then people fill in the blanks of their history and was there an illness, when did the drug use start, if it started when they were young. And so you can pick up clues, and I'm sure as you're reading through this, you're like, he was involved in a car accident. So if you're not in the field of brain injury, if it's not on your radar, it may not occur to you to think, wow, perfect storm, right? Next slide. And so again, with this person that I made up out of whole cloth, they dropped out of high school. Oh, well, we have at the OFR meeting, we have the school counselor. Can you tell us what was their school career like? What happened before they dropped out? Oh, but they did work. Okay, that's great. They're able to work periodically. They had some short stays in county detention. So they're known to parole and probation. They sit in our OFR team. So tell us about that. And on several occasions, they really were motivated to change, but they left prematurely that treatment program. Well, was it because they were not motivated? Or maybe the treatment program wasn't brain injury informed and they didn't offer enough kind of external support, like writing things down and having groups that provided maybe a graphic organizer so they could help focus their attention. And so it just gives you a way of picking up clues and then offering perhaps some strategies moving forward in some of these environments. Next slide, please. So again, you're just looking for clues: suspension, disciplinary issues, assaults and falls, motor vehicle, all-terrain vehicle accidents, organized or recreational sports injuries. Did they drop out of high school? Pattern of conflict, cycling through criminal justice and behavioral health treatment programs. All these are clues. It's not a diagnosis, of course, but it's was there a cut point in that person's life trajectory? They were doing great, or they were doing neurotypically fine, and then all of a sudden they kind of fell off a cliff. What happened? Did that car accident happen prior to that? Worth exploring. Next slide, please. And again, you want to look for any illnesses, chronic pain, right? Because that could be a tip that they were induced or inducted into opioid use that was above and beyond the prescriber's intent. Do you know anything about prior survived overdoses? Because sometimes you hear folks who, they came through rehab, they went away for a program, but they didn't last. Well, they already had a few survived overdoses. Maybe now they're living with an acquired brain injury that cognitively puts them at a disadvantage, engaging in treatment the way it's typically provided, in a way that has quite a heavy cognitive load, a lot of talking, a lot of negotiating interpersonally, and it might be just beyond somebody's cognitive capability after a history of acquired and or traumatic brain injury. Any health or learning issues, before the age of 10, during adolescence, early adulthood. Again, it's just clues. You're not diagnosing, but you're like, I'm wondering. Next slide, please. So this is just kind of a summary of all that, but I can't stress enough the history of prior overdose. That is a huge red flag. Next slide. So for this individual, I didn't point it out verbally, but they have bacterial meningitis. That is known to cause an acquired brain injury in some cases. And then, of course, that external force, such as what occurs in a motor vehicle accident, which was known to the OFR. Next. So my recommendations, and they're kind of right in line with a lot of what Melissa already said, but one of the things that you can do as a state program, if you have the capacity, and if you're a federally funded TBI program, you might be able to do this, is to just provide some screening, some tools, and really get the word out when you do your outreach about brain injury informed strategies and accommodations. Connect with your certified peer specialist, if I haven't said that 10 times already. Reduce the cognitive load for treatment offered in group settings, and refer to your brain injury association or alliance. I can't tell you how many times I get blank looks when I mention our Brain Injury Association of Maryland being a fantastic resource. And they also understand the link between opioid use disorder and possible acquired brain injury. Next. And I just wanted to show this to you. So somebody who works at one of our harm reduction centers in Baltimore City, they had actually been a case manager for the Brain Injury Association. They're a social worker, and now they're at this harm reduction center. And I went for a tour, and they said to me, brain injury informed supply table, and you will note everything's labeled. There's signs over everything. There's description in plain language. It's just so brain injury informed, I wanted to cry. So it's so simple. This does not cost you one cent to organize things in a brain injury informed way for folks seeking supports in the community who use drugs. Next. And I think I'm going to skip through because Melissa beautifully discussed next of kin, and I endorse next of kin interviews because I think that's another way of picking up those clues of a hidden brain injury. Next. Those are great resources, fantastic resources. NASHIA has a wonderful set of resources, including these, on their website. Next. That's just my sources, in case you want to do some additional research in your spare time. And that's how you can get a hold of me at the Maryland Behavioral Health Administration. So thank you so much. Thank you.
Thank you, Stasia and Melissa. Hi, everyone. I'm Zeta Ricker, Director of Strategic Partnerships and Policy with NASHIA. And in case you were not already compelled by Stasia and Melissa's comments to interact in this space and get involved, which I cannot imagine you won't be now, I just wanted to provide some additional context about the focus on brain injury within the co-occurring challenges of substance use disorder and behavioral health, and also within the prevalence in the criminal legal system, and to really highlight that this is something that the administration cares about and the agencies that are focused on this care about, and there's so much opportunity and resources to help support your work in this space. First wanted to thank our COSAP partners for already working in this space. NASHIA partnered with them recently to put together 4 different podcasts on the intersection of deflection, brain injury, and substance use disorder. And those are available here and on NASHIA's website. It might be an additional resource to share with your partners in this space. Next slide. NASHIA is also really grateful to be engaged in the Link Center Policy Academy, which aims to support states to ensure capacity building and relationships to support people with brain injury, IDD, and other cognitive or communication differences who are in need of 988 or other crisis response. Right now, several states are engaged in this policy academy to build these systems of support. And really, I share this again to highlight that brain injury is at the table in these conversations at a federal level, and hopefully that is encouragement for you to bring that to your state systems. Next slide. We are also really grateful for Congress a few years ago passing the TBI and PTSD Law Enforcement Training Act, which as a result of that work, the Department of Justice, through the Council of State Government, one of their technical assistance providers, it has developed a report that will be released very shortly about the prevalence and nature of brain injury in the criminal legal system, some ways to support people with brain injury within these systems, and some finding and recommendations for the Department of Justice to continue this work, which we know will definitely overlap with what you've heard today. There will also be a webinar expected, I think, in the July timeframe when this report is released to highlight these activities. Next slide. We only have 2 minutes left. Just want to again highlight the importance of partnership. Stasia and Melissa included a number of different partners and things that you may want to think about. Just wanted to provide at a more macro level some of those partnerships that are so important to ensuring that you are helping to support people with brain injury within these systems. And that is all I have. Thank you so much.
Zeta, thank you so much. And Melissa and Stasia, we so appreciate all of that content. I know it was a lot to cram into an hour. I saw that we had a couple of really interesting comments that people had shared in the Q&A. Anything y'all want to just touch on quickly that's there? I know somebody asked about doing overdose review, not necessarily tied to fatality, which is a great point, but often a challenge, right?
Yeah, I'll just say information sharing can be challenging even when you're doing it with legislation or statute support and the individual is deceased. And so having individuals who are currently alive and still there, that can make the complexity of sharing information about them. The other thing we have found, so our recommendation is to do a deeper review of prior non-fatals in your case review of an individual who has died. And then my last comment is sometimes when you review non-fatal overdoses, what people end up doing is more care coordination or case management, and that less of the system change, which results in that individual needs being met, but not the other general population being benefited. So.
it's so important to just be paying attention to those risk factors, as Stacia was pointing out, you know, so that you can connect all the dots in your state. Speaking of connecting the dots, if you don't know about your OFR in your state or, you know, in your own program, check that out. Melissa would probably be very happy to guide you toward that. And yes, everyone is available for training across the US. I hope I'm not speaking prematurely on your behalf. Just a few things as we close out, some up and coming opportunities for training. If you're interested in taking a look at disability innovation funding and leveraging that in your state, join us on May the 21st to hear more about that. We have 2 more parts to our vulnerable population series coming up. One is on brain injury and human trafficking, and then one is on MMA and UFC and brain injury. We have a workshop on data visualization, and we're going to close out the year with making a case for state general revenue and supporting brain injury. So join us for those things. You can register for all those on our website. We hope you enjoyed this content. We would love to see you in Eugene, Oregon for our annual conference. There's information on our website as well related to that. And all of the trainings that we do are available on our website. They're archived. Don't forget to complete your evaluations when you get those via email, and have a great day.
Thank you. Thank you, Maria. Thank you, everyone.
Thank you.